always go back that way.
Well, sometimes they used to be up here. Now you see it. So then we start talking about this presentation is actually in two parts. I still use some of the stuff from the old class, and so I haven't combined it yet. So we're going to start with the pelvis and the perineum. The perineum is the area between the genitalia and the anus. So, we'll start by talking about the arterial supply to the pelvis. We'll talk about the bladder and all that 2 weeks ago. And today we're going to talk about the arterial supply to the pelvis. And we're going to discuss the floor of the pelvis. And then we'll start into the reproductive organs. So, we that's up a couple of weeks ago about the arterial supply to the abdomen. We had the common iliac artery on both sides. And I'm going to kind of preface this with saying that the circulation is different in everyone, especially you ladies. It can be different from one side of your pelvis to the other. So I'm going to give you what is considered standard, and we'll talk about that a little bit. And you all can, when you look at those videos I put on there at the anatomy lab, if you do, or whenever we see in fourth quarter in the lab, you'll see what I'm talking about. There could be quite a bit of variation in this, but that's just how we're put together. So we have our common iliac splitting into an internal and an external iliac. External is not labeled right here, but we have the label on the other picture. External iliac doesn't really do anything in the pelvis at all. External iliac gives us one little artery right here called the inferior epigastric that we talked about way back a while ago, 3 or 4 weeks ago, maybe 6, something like that. And then the external iliac artery becomes the femoral artery and supplies the majority of the lower extremity. That's underneath the little ligament that we discussed a few weeks ago. And that's where it changes names.
What did you say the iliac turns into?
Well, the external iliac turns into the femoral artery.
Thank you.
Internal iliac gives us a bunch of different branches. Now, supposedly, if you are following the textbook like you're supposed to, your pelvis following the textbook, you're going to have an internal or an anterior and posterior division of the internal iliac. Not everyone necessarily has this. Sometimes people don't necessarily split into this. And if you don't, that's fine. You're still going to have arteries going where they need to go. So you have this anterior division right here, giving us our obturator artery. Comes off right down through here. And we have our umbilical artery right there. Umbilical right there. The umbilical artery, we actually talked about this when we talked about the posterior abdominal wall. We had that medial epigastric ligament. And that covered what's called the obliterated umbilical artery. It's obliterated because it doesn't really do anything outside of the pelvis in the adult. Inside the pelvis, you still have a little piece of it. And that gives us what's called the superior vesicular artery. And they go to the top of the bladder. Then we have our obturator artery right down into here. It's not labeled here, but it will be on the other picture. Then we have the inferior vesicular artery right in here, going over here to the bladder. artery going back to the rectum called the middle rectal artery, right there, goes to the rectum. And we had superior rectal artery coming off the sigmoid artery, middle, and of course there's inferior rectal artery come off of the pelvic circulation. So the pelvic direction supplying the rectum. You also have separate venous drains for the rectum. You have superior rectal vein, and then you have a middle and inferior rectal vein. And they drain on different paths. Superior rectal vein ultimately is part of the portal system and ultimately goes directly to the liver. Middle and inferior rectal vein go into the inferior or internal iliac vein, and then ultimately back up to the IVC. And this becomes important when we're talking about patterns of disease progression, especially in the case of colorectal cancer. Someone who has colorectal cancer, it's like a third or fourth leading type of cancer, especially now. If you have it in the superior portion of the rectum, it goes to the liver, ends up metastasizing to the liver. Now, the inferior portion, or the middle portion of the rectum, it will end up going to the IVC, which IVC also has tributaries from the lumbar. So it makes a real good path for the metastasis to go to the lumbar spine. And you all will see this in practice. I've seen several cases where the woman is had it, you know, again. And from the couple didn't know that they had it, but it will end up going to the lumbar spine. So that's why the importance of case history comes into play. So you will, when you're talking to someone who has this, has low back pain, doesn't know why they have low back pain, just has low back pain, kind of progressively getting worse. You want to ask them about not only bladder but bowel control, and also if there are bloody or loose stools on a regular basis. Now, if they do have loose stool on a regular basis, it may just be IBS, and you can treat that actually pretty well too. But there is a chance that you may have something else going on, especially if they're a little small. So that's something to keep in the back of your head. Is this going to walk in the door every day? But are you potentially going to see it over a 30-year career? Good chance, at least one. One lady that we knew she had colorectal cancer. She was actually supposed to be cancer-free. She came in and had this low back pain. Just didn't make sense why she had it. And here's the kicker with this. It metastasizes to the lumbar spine. It has to be pretty advanced before it can show up on plain film X-ray. And she had radiation therapy as well as chemotherapy, so I wouldn't have gotten X-ray. She had enough radiation. I wouldn't have gotten it. But something just didn't seem right, so I adjusted her and it didn't really make much difference. So she came back to the oncologist. And unfortunately, she was gone about 6 months. She kind of sad because she had something to do. So you will see some of this, not every day, but you will see some of this. Then we have the inferior gluteal artery right here. Now, right here, this is the piriformis muscle. We'll talk about the piriformis muscle in a few minutes. But inferior gluteal artery actually connects the pelvis, doesn't do anything inside the pelvis at all. It supplies the gluteus maximus. And then this anterior division becomes the internal pudendal artery. Internal pudendal artery supplies the perineum, supplies the inferior portion of the rectum, and supplies the genitalia. Goes up between the perineum and kind of makes its way through there, and eventually supplies the genitalia. We'll talk about that in a few minutes. So then back here on this posterior division, a lot of times you don't necessarily have separate posterior division arteries coming. But you have this superior gluteal artery supplying the gluteus medius and minimus, and you have a lateral sacral. Remember, we had the median sacral artery coming out of the bifurcation in front of the L4 for the ilium. So this gives you a lateral sacral artery. That supplies the sacral spinal, or not forward, but the common plane. And then we have iliolumbar. Kind of makes its way back up. And if you look back in your notes, we talked about 4 lumbar arteries. L1, L2, L3, and L4. L5's got to have blood supply as well. That comes from the iliolumbar artery, as well as supply to the top of the ilium. So now here's a little bit better picture of that. A little bit more complete picture of that. And so I'm going to mention a couple of things here, and actually we're going to come back to them when we start talking about the reproductive why. But you have, which is a female pelvis. So here we have our obturator artery, and our superior, here's our umbilical artery, and our superior vesicular artery going over to the left. Now, notice here there is not any mention of inferior vesicular arteries, not directly off of the common ilium or the internal ilium. You don't really, ladies don't really have inferior vesicular artery. You have a uterine artery and a vaginal artery. So uterine artery goes over, obviously, to the uterus. Vaginal artery goes to the vagina. Uterine artery also makes up part of the arterial plexus surrounding the ovaries. We talked about that a couple of weeks ago. Now, you may have a couple of branches coming off of this thing going up here to the bladder, but you don't really necessarily have a inferior vesicular artery. Do have inferior rectal artery right here coming down here to the rectum, right there. Middle rectal artery right here going over to the middle part of the rectum. And we do have the internal pudendal. Internal pudendal is the terminal portion of the anterior division of the internal iliac artery. That's the part that actually exits the skull, or the skull, exits the pelvis. And you all have done axial skeleton at this point with Dr. Wilson, right? I know you haven't built. So you talked about the pelvis, and you talked about the greater sciatic notch, and sacrotuberous, sacrospinous ligaments, all of that sort of thing. This internal pudendal artery passes between the sacrotuberous and sacrospinous ligaments. There's a little opening in there called Alcott's canal. And it passes through there along with a nerve we're going to talk about it as well, making its way to the genitals. Now, are any of you riding bikes on a serious basis? Do I? Yeah, let it do the work, right? Let the motor do the work, right? Well, if you've ever seen a bicycle seat made for a guy, it's got 2 notches in it. And that's why those notches are there, so you don't compress this internal pudendal artery. And there's a nerve that goes along with it called the pudendal nerve. I mentioned the other day, we'll talk about it again this morning. That is the nerve to the genitalia, or most of the genitalia. And so you probably don't want to compress those. And that's why the little notches in the bicycle. And you can see right here, the veins correspond with the artery. We don't really talk about veins per se as a separate topic, but there are veins that go along with each one of the arteries. If there's most of the time when I mention veins, yes, that's right.
Go back one.
It could, absolutely, because it's talking about blood and nerve supply to the genitalia. That's the reason why they see it. And y'all taking obviously out of the people. So my pelvis is like this. You ladies' pelvis is like this. So when you're on a bicycle seat, you ladies are sitting more back on your butt. Guys are sitting more up on their period. And that's the reason for the difference. You ladies don't have to worry about this. because of the angle of your ilium more wider, you're not going to compress these structures. And that's why ladies don't really worry about having a seat like that, but we do. Absolutely. And can actually cause all kind of other stuff too, cause a numbness in the area between the legs, behind the genitals as well, called straddle numbness. Or saddle, or straddle, saddle. All right? So veins right here, no major ones are in there, but keep in mind there is a vein that corresponds with each one of these arteries. So here's a little closer up picture of everything with some of the extraneous material removed. Here is our sacrotuberous and sacrospinous ligament. Internal pudendal artery making its way out here. And you can see how it supplies most all of the genitalia, with the exception of the anterior portion of the scrotum or blade. That actually comes from the external as well. It usually comes off with the inferior abdomen. But here you can see male and female, and you can see the course of that internal pudendal artery. All right, so for the pelvis. For the pelvis kind of supports all the pelvic organs and all the abdominal organs too. You have the peritoneum. We talked about that. This one, right, the peritoneum, colon, mesentery, all that, helping hold this stuff up. But the peritoneum does not go all the way down to the pelvis. It covers the top of the pelvic organ. And we talked about this 2 weeks ago, that rectovesicular and rectouterine and uterovesicular pelvis form by the distal peritoneum breaking over the top of the pelvic organs. So we have to have something to kind of help hold those in place. And we have a group of muscles right here. Some of these muscles are just there to support the pelvis. Some of these muscles actually help with movement of the lower extremity. And all of them together kind of come together to make a pelvic, what's called pelvic diaphragm. So we have two diaphragms. So first off, back here in the back, we have the piriformis. Piriformis actually is a lateral rotator of the thigh. Makes your leg go out like that. It's the landmark that separates superior and inferior gluteal arteries from one another. That's one of the names for the relationship to the piriformis. And then you have the sciatic nerve emerging from the pelvis we talked about a couple of weeks ago. Sciatic nerve emerges from the pelvis and runs down the back of the thigh and passes underneath the piriformis muscle. And some of you may have heard of piriformis syndrome. There's a couple of different variations of this, where the piriformis muscle is interfering with the sciatic nerve, whether it be a structural problem or a congenital problem, because sometimes parts of the sciatic nerve can actually pass through the middle of this muscle. Occasionally it comes out of the body. That's really weird. I've found cadavers a couple of times. And if it's congenital, there's not much you can really do to ever cure it, I guess, because it requires some pretty invasive surgery to cut through the gluteus maximus to get down there. But you can treat it. A lot of times, pelvic and sacral subluxation, femoral subluxation, will all cause this, come together, combine this, cause this piriformis muscle becomes spasmodic and press on the sciatic nerve. A lot of times it'll cause numbness down in the blood. Especially when you're sitting cross-legged, we call crisscross applesauce or something goes for it. And you're sitting like that sometimes, you'll experience something. But then you have another muscle back here called the coccygeus. Goes over the coccyx. Pretty simple, right? And then you have these muscles right here. Collectively, they are known as levator ani. And after this class, unless you decide to really specialize in working with pelvic muscles, you might not really worry about these three muscles individually. So we have the pubococcygeus right here. Then we have puborectalis. It's kind of deep to pubococcygeus. You see a little bit of it right here. We'll go see it better from the other side. And then we have iliococcygeus. All of them coming together to form this pelvic diagram. And that supports everything. Now, these muscles don't necessarily attach to both. They attach to kind of each other a little bit right up here. Attach to coccyx up here. You have what's called a tendinous arch. And that tendinous arch comes off of this muscle right here called the obturator internus. Obturator internus immediately rotates the thigh. Laterally rotates the thigh just like your palm. Passes out through the right side to help laterally rotate the thigh along with your palm. Then you have an operator externus, which immediately rotates the thigh. They cover the operator front. There is an opening right there called operator canal. That's where the operator artery and the operator nerve we talked about a couple weeks ago pass through that canal to supply the medial portion of the thigh. Urogenital hiatus, this area right here. Urethra, uterus, and rectum. So it's obviously a female. Then you have the anterior longitudinal ligaments. You can see a little down in here. And those run down on the sacrum as well. And I'll talk about that with Dr. Lawrence. So now looking from the bottom up. This is the perineum. And in that perineum, you'll have the urogenital and anal triangle. So up here, this is obviously female as well, but here's the vagina. So we have right here in the center, all the muscles kind of come together at this spot right there called the perineal body. That's a common tendon attachment for all these muscles. Then we have what's called the ischiocavernosus right there. Ischiocavernosus becomes contiguous with the erectile tissue in both the penis and the clitoris. We'll talk about that in a bit. Then we have the bulbosponginosus. Bulbosponginosus is a little different in men. Bulbosponginosis in men does not have this opening, obviously. So we don't have this opening at all. And it actually becomes contiguous with part of the penis. And women, it just kind of stops right here. That's the That's the opposite. Then we have a superficial transverse perineal muscle here. And then we have superficial, you're going to have deep, right? So deep transverse perineal is just below. And they all come together right here. Then you have this last little piece right back here called the external anal sphincter. Now you have the internal sphincter too. We talked about it a couple weeks ago. We talked about the anus. And the internal anal sphincter is kind of involved. Not 100%, it's mostly involved. External anal sphincter is a voluntary muscle. So that's the muscle when mom and dad potty trained you learn to control. That's why that's the muscle you control. Sometimes, certain situations, people will lose control of this. Usually very stressful, very serious situations, a lot of times very serious injuries, that sort of thing. Because they are worrying about something else other than controlling the sphincter. So the internal sphincter, if there's fecal matter there, will relax on its own due to pressure, and you'll let go. All the muscles of the GI tract are controlled by not only nerves, but also hormones, and also, yes?
Talking about the sphincter, isn't there really three main times in your life that you completely lose control of it?
All the time somebody dies.
Traumatic event,
Traumatic event.
and absolute death.
Absolutely. It's gonna be, it depends on one person to the other. And you can take, and you're probably saying, "Nice, cut my arm off, and I wouldn't be happy, right? I'm not gonna lose my mind."
Right,
Some people, I'll give them hard tests.
okay.
So, I'm being silly about that, but it just depends on the person about that, how things affect you. But this internal sphincter, when it's pressed against, will relax. Because with the GI tract, you have nerve, you have hormone, but also distension of the actual muscle itself, the smooth muscle surrounding the GI tract. And he'll talk about that with more physiology. Was I on the more class. But it will distend, and that will cause muscle to relax or contract. And that's how you move food down through the GI tract and eventually fecal matter down through the GI tract. So, right here, that's called the perineal membrane. That just kind of covers everything up. If we remove that, you can actually see a little bit of the puborectalis muscle. And I believe my next picture over here has that. Oh yeah, there we go. So here's our puborectalis, and there's our urethra. This is obviously a guy right here. So here we have our ischiocavernosus. Underneath the ischiocavernosus, we have what's called the bulb of the penis. And that's what makes the erectile tissue in the penis. And you ladies have a bulb of the cord. Here's erectile tissue of the cord. Not much, but there. And then you can see right here how we have the bulbosponginosus muscle here. And you can see the external urethral sphincter coming through that. And then right here, this little section where the urethra starts up to the penis and eventually sinks to the muscle. But that's the puborectalis muscle. All right, so male versus female. We're going to talk about female reproductive organs here in just a few minutes. I'm not going to make a big deal about this, other than just kind of show you the differences. So we have the mons pubis right up here. You got fat here. The labia majora, labia minora. Clitoris right up here. The clitoris does have a shaft, not like the penis, obviously, but it does. Then you have a glans, very end of prepuce. So you do have, ladies do have foreskin on the covering the clitoris to help it be protected from rubbing, especially penis or something like that. Rubbing it can be outright. And then we have the vestibule, this whole area right here. Urethra orifice up here. Vaginal orifice down there. Now, hymen actually covers the vaginal opening. Obviously, hymen doesn't stay there throughout your entire life. Back in the old days, whenever people were very backwards about things like this, people used to say you could take your daughter to the doctor and they could examine her to see if she was a virgin, to see if her hymen. That's 110% bullshit. Most of you ladies pull your hymen to some degree long before you start becoming sexually active. And whatever y'all do with that, none of my business, I don't want to. But toward your hymen, at least partly, long before you ever got to that point. Because a lot of times physical activity will cause growth to tear. At least to some degree. It may not completely go through, but it will cause some partial tear in the hymen. Most times you don't even know it. Because we'll pull somewhere along the way, you're doing something. But you didn't really think too much more about it. And think about this thing. If your hymen was intact, could you have a menstruum? Impossible. Because the hymen was covering the other. So, you didn't. You know, I'm not even going to talk about what, when, and why, and all that kind of stuff. Just know that that's not the be-all, end-all when a woman has had sex. Keep that. Alright, so we have what are called periurethral glands. What they do is secrete lubrication. So we'll look at those. Alright, so anal triangle. We talked about this a few minutes ago a little bit. We have the pudendal nerve, comes from S234, internal pudendal artery, comes off in fact, it's a continuation, the terminus of the internal iliac. Comes through the greater sciatic foramen, both of them do. Passes between the sacrotuberous sacrospinous ligament through what's called Alcott's canal, or pudendal canal, and goes through, and it passes through the lesser side. Gives off our inferior rectal, our perineal arteries, nerves, going to the different perineal muscles and the external sphincter. And then gives rise to arteries going to the erectile body. Then you have the dorsal nerve of the penis and the remainder of your pelvic muscle, basically. That's why the bite seats for guys are different. So you do not compress this between your sacred the tubulum of the ischial tuberosity and the bites. You ladies don't have to worry about that because y'all sit a little above. All right, so there's pathway of the nerve right there on the female. You can see how here's our pudendal nerve right here. Internal pudendal artery. Showed you the pictures a few minutes ago. Penis, posterior scrotum. Anterior scrotum comes off of this external iliac. A lot of times it comes off with the inferior gastric. Then here's our nerves, S2, 3, 4, come together to make our pudendal nerve. Now, pudendal pelvis. And there's, I think I should have picture kind of, here are the differences with male and female. All right, so let's take a break. We'll come back and I'll start with the female reproductive. I'll be exactly that. Get way back, settle back. Okay, while y'all are taking attendance, I'm gonna be, the next little bit of this, is gonna be talking about female reproductive organs. Now, everything will be very professional, no giggling, please. I'll try my best not to. If you have any questions about anything that you don't want to ask in front of the class, please feel free to come by my office and ask me or ask me after class. Feel free to. Or whether you want to ask in class, I don't care. Now, if this is going to upset you or offend you, you're certainly welcome to not stay. I'm telling you right now, I'm taking attendance. I don't see why I would, but you never know. This is the same stuff I showed my 15-year-old daughter, so.
Cold.
Not that friend like that, Jack.
I'm here, I promise.
I know you're not that friend like that.
It is, it is. Thank you.
Y'all have not had embryology, right? Okay. Y'all had embryology.
No.
That's what I thought. Now, before you start back, I have combined the male and female reproductive hormones into one lecture. We will not cover all those today, there's not enough time. We may not even get to all the female reproductive stuff. So this will also be, I'll put this in the week 10 folder as well. But this will be the same material, I'll finish the material next week when we can. So we're going to start with the female reproductive system. Now, some of this, I'm sure a lot of this will be something most of you got high school from. I think Charlotte did this in ninth grade or something. Yeah, I knew she did. None of us will come to lecture class. Until she walked in and actually saw that I wasn't there, she thought I was actually going to cover the material in her health line. She said, so, we have the vagina, the external genitalia, labia majora, clitoris, the mons pubis, the cervix, the different layers of the uterus, the fallopian tube, ovarian ligament kind of holds everything up, suspension ligament, broad ligament. Then we have the mesometrium, round ligament. Talk about that. And this a lot of times gets forgotten about the breast as being a reproductive organ, because that's where you nurse children. And it's stimulated by what's called prolactin. All right, so here's a frontal view of the internal reproductive organs. So here we got our vagina. Here is the cervix, right here. The uterus. Cervix is the portion of the uterus that extends into the vagina. You'll see how it's cone-shaped at the very top of the vagina. These areas right here are called the fornix. That's where the word fornication means. Right here in the center, you have the cervical canal. Cervical canal is where the sperm, when they enter the vagina, line up and make their way through the cervical canal and hopefully fertilize Then we have the ovaries right here, held in place by the ovarian ligaments. Now, the uterus has three layers. Has a parametrium, a myometrium, which is the muscular layer. Then lastly, the endometrium. The endometrium is what you ladies slump on every 28 days. When you're having your menses, that's what the discharge is the endometrium coming in, coming out, and making little blood tissue that looks like great heterovascular. And so that's why you have the blood loss with the menses, because you have the little pieces of material in there. That comes from the endometrium. Now, here's just a little close-up picture, a little bit more involved. Now, peritoneum, from the abdominal cavity, makes its way down into the pelvis and drapes over the top of all of these structures. And you can see that right over here. So we have makes up what's called the broad ligament. Now, the ovary right here is sandwiched inside that broad ligament. You have the ovarian ligament right up here. And then you have the broad ligament is further subdivided into the mesometrium down below the ovary, mesosalpinx above the ovary, and mesovarium right here is kind of coming over the top of the ovary itself. So, back over here to this side now, you can see where we have cut the uterus in half. And so you can see the endometrium and the myometrium. Right up here we have the fallopian or uterine tube. Now, I want you to take note right here at the end of the uterine tube. Does not contact the ovary directly. And it's real important. We'll talk about it in just a minute why. So we have the ovarian or fallopian tube are divided into four sections. Intramural, where it passes through the uterus. Intramural just means between the walls. Ephyllus, right here. Ampulla, is a big large part right over here. Infundibulum, right here. And then at the very end, we have, you can see it labeled over here, we have what are called the fimbriae. The fimbriae create a peristaltic action, just like this. So they move the oocyte, once it's ovulated, into the ovarian tube. Or, I'm sorry, uterine tube. So you can see the uterine tube does not directly contact the ovary. So when you ladies ovulate, we're going to kind of go through it. I'm going to go through a watered down version of that in a few minutes. When you ovulate, the oocyte is expelled kind of out into the pelvic cavity, just in the fluid out there. And the idea is these fimbriae are creating a peristalsis and drawing that oocyte into the ovarian tube, or the outline, the uterus. And it's right up here in the ampulla, right in this area here, is where fertilization generally takes place. However, you may have some of these sperm that are very strong swimming. They make their way all the way up through here and all the way out into here. And should they meet up with this oocyte right here, out in this area here before it enters the uterine tube, fertilization can take place out here. And a lot of times what will happen in that situation, that fertilized oocyte will not make its way into the uterine tube. And it will find its way to some other blood supply. A lot of times that's called an ectopic pregnancy. So, and here's the deal with this. You won't know it. You won't know what's out there. Not until it's a problem. And there will be. There will be a problem. It doesn't matter how long it takes before it happens. There will be a problem. Because when this oocyte fertilized becomes zygote, starts producing the exact same hormones it would if it were used to drink water. So when you have take a pregnancy test, pee on the stick, it'll change it. Because you are pregnant. But you're not, you can't carry the baby there because you don't have the support structure. We looked at the mesenteric a couple of weeks ago. It's just peritoneum. So if this thing latches on, that's usually where it does, latches on to some part of the vasculature in the peritoneum. There's no support. So as this thing starts to grow in the bone, it gets too heavy. Too heavy for the mesenteric support. And it packs. And the mesentery is very rich blood. So women will bleed to death before they know what's going on. Then ladies worked for me about 10 years ago. She had one of these. And she was actually, they already found her. And she was actually having the procedure to remove it from her mesentery. And the surgeon, I don't know whether he did something wrong or bad luck or whatever it was, he had it during the surgery. And she was on the table having procedure corrected. And she almost fell. That's how fast the mesentery. So a lot of times, these things will cause abdominal cramping things like that. But just part of the blood test, you won't know. They do an ultrasound. The ultrasound techs can find it. Thirdly, the OBs can find it. And here's the deal. Many of you ladies who went to Keystone Hospital with abdominal pain, they're actually going to do a pregnancy test on you before they even look to see if you have appendicitis or something like that. Because these things will kill you. And I know there's some nonsense on the National Geographic Channel about somebody having one of these things. And it's supposedly ossified. And she, 20 years later, found it. That's because you can't. Nonsense. So, here is, and that's why those occur. Now, if this thing comes out right here and doesn't get swept into the tube, and there's no sperm here to fertilize, it drifts out here to the atmosphere. No harm, no foul. Your body will just absorb it as long as it's not fertilized. It's not going to grow. It's not going to, cells aren't going to divide, anything like that. But this thing will just drift out into the abdomen of the pelvis, and it'll just kind of be absorbed by the body. That everything. Won't matter if you have it or don't have it. Kind of
I have a question. So you said if there's a subluxation in the sacrum, it can affect fertility.
absolutely.
How does that happen?
That's nerve and blood supply.
But how does that affect like an egg being able to attach to it?
Well, it doesn't affect that. It affects the ability of the body to know the object. So you have a nerve plexus that's around all of this from the sacral pelvic sacral plexus. All right, so here we have the ovarian tubes. Main body of the uterus. Now down here is a little bit nicer picture of the cervix. And you can see the cervical canal right there. All right, so yes, it is. I kind of always like to hear the numbers. So how many sperm does a guy have at one time? Millions. Absolutely. It only takes one. I mean, that's right. Millions. So, it only takes one. And so the idea being the strongest of the strongest, the best of the best, are the only ones that make the way through here. Now, of that, let's just say a million. Even more than that. Of that million, couple of hundred might make it this far. So they don't make it out of the vagina. And here's why. The pH of the vagina is very acidic. The idea being that it will protect you ladies from infection and foreign invaders. Parasites, bacteria, viruses down to a degree, are all proteins. Proteins are denatured by acid or acidic environment. It's not as low as the stomach, but it's down there around 3.5%. And so it will hopefully protect you. But the problem is sperm are also proteins. So it will kill those sperm as well. That's the purpose of the urethra gland, guys in them, to help not only give you lubrication, but also they produce lipoprotein to help neutralize the pH in the vagina, at least for a short time. So, well, I'll switch off for a minute. If you're trying to get pregnant, you want to make sure you have neutralized the pH in the vagina. All right, ligaments of the uterus and the ovary. So you have the suspensory ligament of the ovary, right here. You have the broad ligament right here. And then you have the round ligament right here. Oh, sorry, right here. Are any of you ladies familiar, any of y'all period, familiar with Webster chiropractic technique? Anybody in here ever heard of Webster chiropractic technique for pregnant women? So, what does Webster chiropractic technique, what do they do? What can I do when I'm seeing a pregnant woman following at least some of the protocols for Webster chiropractic technique? What do I do? You've heard of it, but you don't know what it is, right? Do I? Absolutely. Absolutely. And you don't think you have done. All these ladies in here have seen it. Heard of it. Okay. Well, part of the idea is to keep that top of the line. Allow the baby to turn head down facing. But you also work with the round ligaments. Now, the round ligaments, you can pick them right across here. You ladies can have to the right. They connect down to the genitalia. And there's a small amount of smooth muscle inside these things. And they will develop trigger points. Just like you have your bicep, whatever. And what the doctor does is go down through here and kind of find those trigger points and release those trigger points. I use an acronym to find them. So I use an acronym on the trigger point. So it helps you to sterilize while the baby is. Now, when you ladies are having your menses, so basically, you're having the same type issue. Your uterus is contracting, your cervix is contracting, your spell and it. So basically, you're having the same type issue. Just not that. But you can release these little trigger points and help the uterus relax and help you pass some energy there and kind of reduce some of the mental pressure. That's all right. So here's a nice little picture of everything. Now, lateral fornix. The reason it's called lateral fornix is because you're looking A to B. The cervix actually projects into the vagina as a cobra shape. So if we were looking into L, it would be anterior fornix, lateral, or posterior. Same. It goes all the way around. Now here we have internal, external eyes. That's the other thing. If you've ever had a pap smear, the instrument they use like a little hatchet with a curved blade on it. So there's a little tip of it that goes in the cervix. And then the OB can spin that collection around and they pick up cells from the cervix. And that's what they take to analyze it to see if there's a cervical circulation. Oh, it's just very general. I've never had it. It's not general. Well, it's a whole lot general than cervical. I've never experienced it. I don't know. I guess it is uncomfortable. I do apologize. And why are they worried about cervical cancer in particular?
It's a result of HPV.
Could be. Reason why you're concerned with cervical cancer in younger women is because this tissue is most active. All of this uterine tissue as well as cervical tissue is most active in your 20s and 30s. So once a month. Don't you rebuild part of this? What it is in terms of poorly differentiated, highly proliferating part, which means it turns over very rapidly and hasn't quite decided what it wants to do. So if this tissue is not a stem cell, but it's not actually a fully formed cell. So if this tissue gets a hiccup in the reproductive coding, because it turns over so rapidly, it's very easy for that little hiccup to become cancerous. That's why it's extremely important that you ladies have your pelvic exam periodically. Extremely important, but even though I guess more uncomfortable than I thought it was, sorry about that. Probably a bad idea to still have this done periodically. I was mad. Okay, got you. I hadn't had one of those yet, but I've heard. Not a good one.
Don't tell him to stop.
So, with this, why is this tissue so susceptible to having a hiccup? Why does it reproduce so rapidly? Why is that, let's say, once you label in the early 20s, 22, as opposed to 50? Most fertile, because you're making estrogen at the highest level you're ever going to make. The purpose of menopause is so that this tissue doesn't keep on functioning at that higher level. Because if it did, at some point, all of you are going to have a hiccup in your DNA at some point. More likely than not, most of you will develop some sort of at least precancerous, if not a cancerous issue with suspicion. That's the purpose of menopause. So women who do HRT still have an increased risk of possibly than necessarily like they might get at 25 years old. All right, so back over here now. Here is our blood supply. Remember we talked about our ovarian artery. Remember that a few weeks ago? Ovarian artery right here. Coming down, you can see the artery supply in there a little bit. Here's the uterine artery right in through here. And you see how they come together and make that ubiquitous anastomosis, supplying the organ. Now, I had a question up here about this. Why does chiropractic care help women reestablish their menses and become pregnant? There are 10 children right now that their mothers were under my care and have not had menses in years. 10 children right now that are on planet Earth because most of y'all heard of this. Have to be careful about taking pointers to some because they are chiropractors. But the reason being is, okay, you've got this stuff here. Whoops. You got all this stuff here. But, you got all this stuff. What tells it what to do? Absolutely right. And you have those pelvic explained. I haven't talked about it yet, just have got. But you have some parasympathetic nerves coming from the same nerve that's going through that side. Parasympathetic is what controls reproductive functions. So if someone has a very nasty circulation, it can interfere with the function of the nerve to the point that it can cause a complete metal. So next you shut it down. Correcting that nervous supply can reestablish the normal momentum. And once normal momentum occurs, ovulation will follow. Had one lady, she was actually a labor and delivery nurse. She was very strong. And came to me about 12 o'clock. Nasty circulation. I can't have a mixed for 4 years. This girl was a labor and delivery nurse. And she, well, so we started working with the same amount of going. We met very well. We tried to reach that. So about 6 weeks in the treatment, she came from. Tell me she never appeared the first time in 4 or 5 years. I said, when you married? I said, you husband and I are if you're not taking me for caution, you don't get killed. You probably are taking for caution. You know, about 6 weeks later, she comes in telling me she's pregnant. Now they got 3. Yeah. Real nice couple. That it absolutely happens. All the time. Some of you have heard of this. I'm sure some of you may be here because of something. So here we have. And the second part of this is what's the parasympathetic nerve also going to help control vascular tone, which will help improve blood supply to the organs. So not only does the nervous system tell them, okay, when you do this, there's a hormone that where the hormone, we've got estrogen and progesterone and all that. But then you have the blood not making its way to the organ as well. If you don't have blood supplying, even that oocyte is fertilized, makes its way down here, and really can't survive. So you ladies probably never know this. A lot of times, pregnancy occurs, but you do not even know that you are pregnant. Very common. Fertilization takes place up here, and it just doesn't implant in the endometrium. It happens all the time. Even to the point maybe implants in the endometrium, but it's not there for a couple of days. You don't really realize nothing will start happening then. And so you have your menses, and you pass out the fertilized zygote at that point, and you don't even know you're pregnant. Not terribly common. All right, so here's a lateral view. Here's the bladder. Here's the pubic symphysis. Here's the uterus. Here's the rectum. Now here is this greater vestibular bone. That's what secretes like hormone. And surprisingly, a little bit of fructose too. The semen has a lot of fructose enough to give the sperm the energy to swim and shrink. But this also secretes a little bit like hormone. Of course, you leave more. I put this picture in here because of this right here. Now here's the uterus. And see how it lays right on top of the bladder. When y'all see the fourth quarter, we have a rendering of a pregnant female that one. Conditioning Imagineers made her pregnant, and we did CT some before, in a pregnant. They did on it. But they, came in there, and the only thing on the animal table was actually not. Everything else was good. They took her and made her pregnant. And this uterus, as the baby grows, grows out like this. Very well. Laying right there against the bladder. And press that bladder against the pubic symphysis and the pubic bone. That's why pregnant women have to pee all the time. That last trimester, some of you ladies know what I'm talking about. That last trimester, Sally she knew all the bathrooms between our house and Marietta. She knew which one you ladies know what I'm talking about, which one she could go in and which one she couldn't. And she had them mapped out. She knew exactly where to stop. And pretty much stopped at the same ones every day. We live about 45 minutes west. So she had this all planned out. But my wife's only 5'2". And my daughter was 2 feet tall. She was 24 inches. So, yeah, she's now Sally's she's not little hips. She's got hips. But yeah, she carried that big old baby in there. And that last couple of months, she had to go stop the bathroom every 10 minutes. Made the mistake of taking a trip up to Pigeon Forge, Tennessee that last month or so. Never again. And it wasn't her fault. Never again.
What's your fault?
Man, it wasn't my fault. I was there, but I wasn't going. All right. So here we have the cross section of the urethra. I talked about this 2 weeks ago. See how short? Now keep in mind, if this was a real person, they'd probably be 18, 20 feet tall. So see how short that urethra is? That's why a lot of women postpartum experience incontinence. Because all the diaphragm muscle we were talking about earlier, as you can imagine, it's very short during pregnancy. First of all, they're holding up an extra 18, 20, 25 pounds. Plus, okay, you see the cervix over here. Pushing something the size of a big watermelon through there. It's obviously going to be short. And so, that's why a lot of women will experience incontinence postpartum. Now, there are things you can do to prevent that. It's part of Webster technique. Where you can work with the pelvic floor muscles, different things. But there are ways to help prevent that and correct it postpartum. It's pretty simple, if you know what you do. Biggest thing is making sure that pubic symphysis and the sacrum are right. All right, external genitalia. And we talked about this a minute ago. So clitoris. Clitoris I want to talk about specifically because it is a homologue to the penis. So you do have erectile tissue in the clitoris. You do have a prepuce, which is the proper name for portion. You do have a prepuce covering the prepuce tissue. But there is a slight bit of erectile tissue in the clitoris. However, the urethra is one. My urethra runs right along with the erectile tissue in the penis. But ladies, your urethra is slightly below the clitoris. And I'm sure you all know that. But we do have the same muscles. Ischiocavernosus and vulvar spondylosis. All right, so here we have our process of ovulation. So what happens is you have this primary follicle with a primary oocyte inside. Now, for whatever reason, the body decides, That's the other side that's gonna be obvious. So it will cause, not only cause it, but the oversight itself start growing. One per month, usually. Sometimes, but usually just one. And I don't know exactly, I don't know anybody knows why the body chooses to cause that one, not the one side. I don't know if anybody really knows that. But it does. And it starts to grow. It develops into a larger and larger follicle. And we're going to go through a little bit more of this in a second. Then finally, we have a secondary oocyte. Now, the process involves reduction of chromosomes. We're going to go through that in just a minute. So you actually end up having two oocytes. One functional and one not functional. That's called a covert body. And if you've ever seen these old movies with Arnold Schwarzenegger and Anthony and conversations, and the V is supposed to be on the practice side, though. Yeah, that's what you actually said. And I guess the veto would have developed overlap. It has to do with the division of the cytoplasm. One half gets the cytoplasm, one doesn't. Because at this point, we are 46 chromosomes. We have to reduce that to 23, so you get 23 from the mom and 23 from the father. Then you don't actually ovulate. That's the oocyte liberated on, I like that picture. Liberated oocyte. And hopefully that makes its way up through the femur. Then what happens? This follicle forms what's called the corpus luteum. And the corpus luteum can continue to grow and secretes progesterone. Progesterone is there to stop menstruation. And so, this corpus luteum will produce progesterone. If the oocyte is planted, the corpus luteum continues to produce progesterone and still will send the egg. So, sometimes it takes more time to do it develop. Then the placenta will start producing progesterone. If implantation does not occur, then this corpus luteum just disintegrates and becomes what's called a corpus callosum. Now you can look at a cross section of a female's ovary, and you can count the number of corpus albicans there, and tell how many times she has ovulated. I don't know why you want to do such. But if you somebody, I would think nowadays with MRI technology, probably relatively easy. But you can absolutely count the number of these. That's every time. Yeah, that's not a scar. Now, with that said, are you ladies ever going to run out of oocytes or eggs? You're going to run out of, you live to be 200 years old, you run out. You got hundreds. So, are you born with oocytes? Absolutely. They start the development process and stop at primordial time. And they hang out there until you start puberty. And that's whatever the growth of continue. Now, I'm giving you a very short, very condensed version. I used to teach in the neurology school here in Houston an entire 2-hour lecture to genocide. After a 2-hour lecture, but you aren't going to chiropractic. You need to go to places that you don't need to know how to do it in the first place. All right? So here we have just kind of an overview of what's going on. But you ladies are born with hundreds of oocytes. I mean, I imagine if you lived long enough, she would probably run out, but that did take 2 or 3 years to do that. We don't have to worry about that. Now, guys, this is kind of next week's material, but when you're born, do you have any sperm? No, none at all. We have the primordial cells produce sperm, so we don't have any sperm. You don't start producing sperm until you start eating. Then you start producing it. How long can you, once you start puberty, how long can you produce sperm? So you die. Absolutely right. Now, will the sperm count decrease? No. It will most get most time because of a decrease in testosterone. We'll talk about that. But you don't keep testosterone up. You ladies stop ovulating something wrong. It's called menopause, right? And here's just another little picture of the same thing. And there's a nice little picture there of how the corpus luteum is formed and then eventually disintegrates into pregnancy. Okay, ovarian cycle. So the follicle grows, then fungicide is released, and then it begins to form into corpus luteum or material. So here are the dates. So around the 14th day of your menstrual cycle. What day does your menstrual cycle start on? Oh, come on, lady. What day does your menstrual cycle start?
First day of the period. First day of
First day of your menstrual. Absolutely. A lot of times folks think it's the last day of the month. That's okay. They won't have kids. But if you're trying to time this, remember it starts on the first day. Why does it ovulate on the 14th? Why do you ovulate? Do it? Yeah, it's right. But why do you ovulate then?
Is it the hormone that you produce?
Hormone produced, yeah. Menstrual cycle, yeah. Because after day 6, I got 7 in here, but you all of you know about exactly that. But as you are having your menstrual cycle, the endometrium is getting thicker and thicker. And I got a picture of that here. So at day 14, it's getting real nice and thick. And so at that point, we have the tissue and the blood supply, if ovulation occurs, for you to become to actually expand the zygote. Because it continues growing up until this point, about 27 days, and then start dying. So pregnancy will occur somewhere in this vicinity right here. Of course, here you gotta have the corpus luteum producing the progesterone at its highest level right here about day 21. How long will sperm live inside your body?
5 weeks.
4 or 5? So keep that in mind as well. Now, meiosis. Meiosis only occurs in reproductive cells. The purpose of meiosis is to reduce from 46 to 23 chromosomes. I'm not going to make a big deal about each one of these phases, but I do want you to be aware that the cell divides. From phase 2, we have 2 different zygotes. Then we have metaphase and anaphase. Then eventually down here, telophase 2, this is where we have 2 23 chromosomes south. One of these dies off the middle. So we're going to talk about that and hopefully get to it today. If not, and the other one right here, what happens if one of these survives and one of these dies off, becomes the polar body. Yes, I'm sorry.
How many how many chromosomes do you say that the starting cell has?
46.
46.
When you see 23 in me, that's 23 men. So you get 23 from the mom, 23 from the dad. And then that makes the cell whole. What happens if this doesn't occur and you still have 46 chromosomes? Can that zygote, the 46 chromosomes, be fertilized and implanted and grow and be okay? Sure, absolutely. Happens from time to time. Testing is back on. As long as you have at least 23 from dad and 23 from mom. There's a condition I'm going to what's called a persistently staying belief or something like that. But you can absolutely. Now, if you have a pickup with one of their mom or dad, that's where it's genetic effect. Depends on what you're talking about. Trisomy 21, trisomy 20, some of them you can live, some of them malleable you can't. Some of them you won't make. Most of the time, those don't even apply. All right, so here we have, this is where I'm going to stop, right here. So here we have the ovum making the primary oocyte, dividing it into secondary 46. Then those secondary oocytes divided to the actual oocyte. So over here, two of them just die out. Then right here, one of them becomes a viable ovum, one of them becomes a polar body. So each oogonia yields 3 polar bodies and 1 functional ovum. Sometimes this doesn't happen. Sometimes 2 of these. That's what's going to. And there's just another little picture of how all this happens. So, you can see right there with us, spermatogenesis. Each one of our primary spermatocytes will actually yield a full functional body. So the ratio is 4 to 1. And that's what we need to have because so many of the sperm do not make it to be able to fertilize the ovum. Don't even make the surface. So that's why we have so many more sperm than the oocyte. Plus, think about this: if you had 4 and 4 here, there's one if you had 1. Bad. And there's just another little picture showing all of that. And then we'll talk about the diploid, the haploid. And we will pick up with that next week. So I'll see everybody.